Ready?
So once we hit start, it takes a few minutes just for people to kind of be let in, or however this magical webinar experience happens. And I don't want to get too far ahead of ourselves before we have everyone in the door. I hope everyone's enjoying the new format for our GYN cancer seminar. In previous years, it's been a half-day event from 1 to 5 p.m., which I know is a long time to sit. And I think that our feedback reflected the same. So this is the first year that we've had these lunchtime seminars, 12 to 1 each Wednesday. We will culminate in a Q&A panel with survivor speakers on Wednesday, September 25th at 7 p.m. If you've missed the previous recording with Dr. Cynthia Angel last week, it is available on our website, as well as Dr. Rubin's will be after today. So don't feel as though you've missed it if you can't join us at noon. And I also just wanted to put in a plug for next week at noon. We'll be joining a few of our folks from the URMC to talk about sexual health during and after gynecologic cancer treatment. Huge topic. That recording will be made available as well. And just a few things to mention as we get started. There are closed captionings available. So you just would click on the bottom of your screen to make that happen. And there will be a brief survey that pops up at any point that you leave today. And we appreciate and utilize all that feedback to help bring programs that are appropriate for you. Now I am really excited to introduce Rachel Rosen-Simpson, our program manager.
Hi, everyone. Thank you all so much for joining us today on our second webinar for Gynecologic Cancers Awareness Month. This week, we have Dr. Nicole Rubin, who's going to talk about managing the long-term side effects of treatment of chemo and radiation for any gynecologic cancer. And Dr. Rubin works for the Rochester Regional Health System. And although it sounds like Dr. Rubin is a transplant to Rochester, and we're very grateful to have her expertise here, she grew up in Connecticut and completed all three: undergraduate degree, medical degree, and residency training at the University of Connecticut. And after residency, she completed her fellowship at UC Davis in Sacramento, California, in gynecologic oncology as a specialty. Throughout her medical career, she's been recognized for her dedication to patient care. So thank you for sharing your time with us. She's a proud inductee of the Gold Humanism Honor Society. She provides compassionate and personalized care to a diverse patient population, prioritizing all patients' well-being and dignity. And she's committed to helping everyone feel safe and empowered as they navigate treatment. So in the spirit of education and empowerment, take it away, Dr. Rubin.
Thank you so much, Rachel and Christina. And I want to say thank you to the Breast Cancer Coalition for inviting me to speak today. I'm just going to get my slides set up. There we go. So welcome everybody. I'll be speaking about the long-term effects of chemotherapy and radiation for survivors of GYN cancers. Our objectives today is to briefly review the 5 types of GYN cancer, discuss the state of survivorship in the United States, review common long-term side effects of chemotherapy and radiation, and review strategies and resources for managing these side effects. Just a few disclosures. So very importantly, today we'll be reviewing some general information, but I'm not able to provide specific medical advice in this talk. These strategies and treatments, I will be talking about may or may not be helpful in your specific situation, and they may or not be safe. So please discuss with your oncology team or your primary care provider before initiating any of these strategies or treatments to make sure it's a safe option for you. There are 5 types of GYN cancer. So there is endometrial cancer, which we also lump in and consider to be a uterine cancer. The endometrium is the lining of the uterus. And so uterine cancer includes cancers that come from the lining of the uterus, but also from the wall of the uterus. Our second type of GYN cancer is ovarian cancer. When we're talking about ovarian cancer, we're usually talking about a combination of 3 different types of cancer that we lump under ovarian cancer that all behave the same way and are probably variations of the same type of cancer. And that's ovarian, fallopian tube, and primary peritoneal cancer. The third type of GYN cancer is cervical cancer. Cervical cancer affects the opening to the uterus, called the cervix. There's also vulvar and vaginal cancer, our fourth type, which we generally think about as being the same larger disease type. And then there's a very rare type of GYN cancer that we don't talk about very often, but it's called gestational trophoblastic neoplasia. And it's a type of GYN cancer that can mimic pregnancy tissue and primarily occurs in people who have recently had a pregnancy of some sort. It's pretty rare and won't be one of the major focuses of our talk today, but I did want to make sure that we included it. In 2024, about 109,000 people will receive a new GYN cancer diagnosis. The most common GYN cancer in the United States is endometrial or uterine cancer with about 68,000 folks. Ovarian cancer, 20,000 folks this year. Cervical cancer, 14,000 folks with a new diagnosis this year. And vulvar and vaginal cancer, about 7,000 folks. The state of survivorship. So by 2030, there are expected to be over 1.5 million survivors of GYN cancers in the United States. And with continued advancements in early detection and treatment, the number of survivors is expected to grow, which is a really exciting thing. Currently, our best estimates are that there are about 860,000 people living with uterine cancer, 300,000 living with cervical cancer, and 240,000 living with ovarian cancer in the United States. Vulvar and vaginal cancer are pretty rare, and so knowing how many survivors are currently living with that cancer, that information is a little bit more difficult to come by. One of the first things that I want to talk about is the risk of secondary and new primary cancers long term. So when somebody has been through a cancer diagnosis and cancer treatment, the treatments that they receive for their cancer can carry some risk, very, very small risk and rare risk, but can carry some risk of developing a secondary or a new primary cancer in the future. Some of that risk is also associated to risk factors that had to do with the first cancer diagnosis in the first place. Some of the specific things we think about, so for folks with ovarian cancer, chemotherapy, and more importantly, PARP inhibitor maintenance therapy. So drugs like olaparib, niraparib, which are used for maintenance therapy, carry a very rare risk of developing a blood cancer called MDS or AML long term. That risk is very, very rare, and it's not something that should preclude these life-saving treatments for folks, but it is something that we want to be mindful of long term. We do generally recommend that folks who've been on chemotherapy at some point in their lives or received a PARP inhibitor should get an annual complete blood count once a year to make sure that the different blood counts are still all in line and there's no signs of any abnormalities. For folks who are endometrial cancer survivors, they often will have radiation along with chemotherapy as part of their treatment plan. Pelvic radiation does carry a very, very rare risk of predisposing somebody to developing a specific type of cancer called a sarcoma in the pelvis. And so folks with endometrial cancer who've received radiation should have a pelvic exam once a year for the rest of their life to monitor for that. And that pelvic exam doesn't need to be with a GYN oncologist. It could be with your primary gynecologist, or it could be with a family medicine or internal medicine provider who's comfortable providing that sort of exam. For folks with a history of cervical, vulvar, or vaginal cancer, they are also at risk for any of that long-term risk of chemotherapy and radiation, as chemotherapy and radiation are both standard parts of treatment for those cancers as well. But unique to those cancers is that oftentimes those cancers develop because of a persistent infection with the HPV virus. And HPV can cause other types of cancer as well, including head and neck and anal cancer, most importantly. And so it's important for folks with a history of HPV-related cervical, vulvar, and vaginal cancer to be aware that because they've already had one HPV-associated cancer, they are at increased risk of other types of HPV-associated cancers. Smoking is also very closely linked with a risk of cervical, vulvar, and vaginal cancer. And so in folks who have a history of tobacco use and a related cancer, we do worry about lung, head, and neck, and bladder cancer. The other thing that I want to make sure we mention is that there are some chemotherapy drugs that can have long-term effects on your heart. So it's important to talk to your oncologist and know, whether that was a treatment that you received or not. And we have these really incredible newer immunotherapy drugs and targeted therapies, which have completely revolutionized our field and given so many people their lives back and been able to cure disease or stabilize cancer that otherwise might have not been very treatable a couple years ago. These drugs work incredibly, but there are still things that we're learning about them, and some of them can potentially affect the heart, the endocrine system, and other parts of the body long term. And so again, these therapies are life-saving for a lot of folks, but it's important to have a good conversation with your oncologist to know and make sure you understand the treatments that you are receiving and what sort of long-term follow-up might be needed. Additionally, patients who have a hereditary cancer syndrome, like a BRCA or a BRCA mutation, Lynn syndrome, or other hereditary cancer syndromes, are at increased risk of developing another related cancer, not due to already having a GYN cancer or the treatment itself, but because of the mutation itself. And so it's important that those folks are being given the opportunities and engaging in increased screening that's available for breast cancer, ovary cancer, endometrial cancer, colorectal, pancreatic melanoma, just to name a few. More than 50% of GYN cancer survivors experience health concerns and long-term side effects of treatment more than 5 years after diagnosis. And this is something that historically we have not done a great job in the oncology field of supporting folks with. I think that oftentimes we are often so focused on, and importantly so, but so focused on helping people get through their treatment, getting them to remission, that often we forget that while somebody might be in remission, it doesn't mean that everything goes back to normal, either immediately or long term. And that while people, their lives can be saved by this treatment, it can also cause long-term issues that we would need to make sure that we're supporting folks with and also educating folks about. The most common long-term side effects reported by GYN cancer survivors are fatigue, sexual dysfunction, sleep disturbances, neurological issues, urinary issues, bowel issues, memory problems, depression, anxiety, and lymphedema. And so we're going to take some time now to go through those different issues individually and talk both about what they are and about management strategies and resources. The first one I want to talk about is lymphedema. So lymphedema is when lymphatic fluid gets backed up on the legs and causes swelling. Folks who've needed a lymph node dissection, and this is usually somebody who's had vulvar cancer, who's had a groin lymph node dissection, or somebody with ovarian cancer, endometrial cancer, or cervical cancer who's needed a full pelvic or periaortic lymph node dissection, can be predisposed to developing lymphedema. Important to note, a lot of folks these days are getting what's called a sentinel lymph node mapping or dissection for endometrial cancer. And because we don't need to remove a large number of lymph nodes for that procedure, the risk of lymphedema is a lot lower. Lymphedema usually occurs within 1 to 2 years of finishing treatment, but it can develop years down the line, and it can come about very slowly. It's important that we catch it early because it's treatable, but it's not curable. When we identify lymphedema early, we can initiate therapies to help potentially reverse, but more likely stabilize or improve lymphedema before it becomes too severe. If we allow it to progress and then allow people's legs, and his legs primarily that are affected for GYN cancer survivors, allow the legs to become swollen over time, it's harder and harder to reverse or improve the swelling as the swelling gets worse. You can see a picture off to the bottom of the screen showing you the different stages of lymphedema. In stage 1, somebody might just notice that their favorite pair of boots might fit a little bit tighter or their pants fit a little bit tighter, but they usually don't notice, any difference in terms of their ability to get around or their day-to-day life. When somebody has lymphedema that progresses to stage 4, you can see there can be truly a tremendous amount of swelling. And unfortunately, when it gets to that point, it can impact mobility and it can be more difficult to manage. Folks who have lymphedema are also at increased risk of getting infections, both in the fluid in their legs and the skin in their legs, and it's important to be aware of that. In terms of prevention, most importantly is keeping active. So keeping our bodies active and moving helps to promote that fluid and being appropriately absorbed from our legs and circulated through our bodies. When we don't move around as much, that fluid can settle in our legs. And if that lymphatic system is not working properly, it can make it really difficult as that fluid builds up to get it out of the legs. Maintaining a healthy weight is also helpful. We know when somebody is carrying extra weight on their body, it can additionally make it more difficult for that fluid to get out of the legs. And I also recommend wearing compression stockings when sitting for long periods of time, particularly if you're planning on flying or planning to take a long car ride. In addition to wearing compression stockings in those settings, making sure that you're getting up to walk every 2 to 3 hours to keep the fluid and blood circulating in your legs. For somebody who does develop lymphedema, treatments include lymphatic massage with a specialized lymphedema therapist, different types of compression therapies. I think most folks are familiar with the type of compression stockings you can buy from a medical supply store or from most big box stores, but there are some more specific um, aggressive types of compression therapy that can be used. And folks who have really limiting lymphedema that's not responding well to massage therapy or compression therapy, there are surgeons who will do lymphatic microvascular surgery to try to reconnect or rebuild those lymphatic channels that get disrupted from a cancer surgery. There are not very many surgeons who do them, but there are a couple. And there are patients, who have significantly benefited from having that surgery done when other things haven't been helpful. Next, I want to talk about neuropathy. So neuropathy is pain, numbness, or tingling in the hands or feet, most commonly in the fingertips or toes. Neuropathy is caused primarily by the chemotherapy drug paclitaxel, which is a standard part of chemotherapy that we use for ovarian cancer, endometrial cancer, cervical cancer, vulvar cancer, vaginal cancer. It's really our go-to #1 chemotherapy. The neuropathy that folks can develop while they're on chemotherapy, if it's very mild, will usually go away when chemotherapy is over. So if somebody just has numbness, tingling in their fingertips and toes, then generally it will resolve in the months following finishing up chemotherapy. But for some folks, if that neuropathy becomes really severe during treatment, it won't necessarily go away entirely when treatment is over. Um, it can be pain, like pins and needles, shooting pain, electric feeling like pain, numbness. Some for folks, it's numbness that doesn't really bother them. Some people will tell me it's numbness that almost feels like they're walking on marshmallows. And other folks can experience that tingling. When neuropathy becomes severe, it can lead to difficulty walking. It can lead to issues of balance and falls. You can imagine if you can't really feel your feet and you feel like you're walking on marshmallows, that can make it difficult to keep your balance. And when it's in the hands, what we worry about a lot is it can cause difficulty with what we call fine motor skills. So people can have issues like picking up change or holding a pen or being able to hold silverware and not drop it. And so if you're somebody who's currently on treatment and you're experiencing neuropathy, it's really important to let your oncology team know so that they can make adjustments to your treatment and make sure the neuropathy is not getting worse. And if you're somebody who's living with neuropathy long term, there are things that we can do to try to help. In terms of things that are sometimes helpful, physical therapy can be helpful. It won't necessarily undo the pain or the numbness, but physical therapists are really skilled in helping you to learn how to engage other parts of your body to help compensate for what might be affected by the neuropathy. So if you're having a lot of issues with your feet and because your feet are numb, you're having an issue tripping over your toes, you keep tripping over your own feet because you think you've picked your foot up off the floor, but you actually haven't fully gotten it off the floor. Physical therapists can really help with different strategies to help engage the muscles in your upper leg and strengthen those or strengthen your core and help you develop different strategies to help reduce the amount of times or how frequently you might be having that issue with tripping over your feet. Appropriate footwear is really important. So wearing supportive footwear that's going to help keep your foot in a good anatomical position so that you're not twisting the ankle or the foot. One of the important things is also seeing a foot doctor for regular exams. We worry about when somebody can't feel their feet very well, that they could have an injury to their foot that they don't know about because it's not causing pain. And if you're not examining your feet regularly, that can lead to a really serious infection or a much bigger problem. Just like folks with diabetic neuropathy are recommended to see a foot doctor. If somebody with severe neuropathy related to their cancer treatment, it can be really helpful to see a foot doctor or podiatrist. Acupuncture has been shown to help with neuropathic pain. There are some supplements that are potentially helpful. You know, there's not clear-cut evidence that you take the supplement, it will definitely fix your neuropathy or relieve your neuropathy. But there is some evidence that it kind of helps your body to restore itself and start to heal from the damage that was caused by the chemotherapy. Those supplements include L-glutamine and vitamin B6. It is something that, you know, in our practice at Rochester Regional Health, we do recommend to folks pretty regularly. And there are also specific medications to help with nerve pain, including gabapentin, also called Neurontin, which is a nerve pain medication. And then also the SSRIs, which are a class of medications more commonly used for anxiety or depression, have also been found to be really helpful for neuropathic pain. And the most common one I prescribe is a drug called venlafaxine. The other important things for neuropathy is preventing and controlling other causes of neuropathy. Like I mentioned, diabetes is one of the main causes. So if you're somebody who's already struggling with neuropathy from chemotherapy, it's important to try to make sure that other things aren't causing your neuropathy to worsen, like poor glucose control. The next thing I wanted to talk about was menopausal symptoms. So for folks who go through cancer treatment prior to natural menopause, the treatments that we need in order to cure and treat GYN cancers often will induce menopause. So menopause, whether it occurs naturally or a cause due to surgery that removes the ovaries or chemotherapy or radiation that turns off or damages the ovary, is the process in which somebody's life, when they're no longer producing normal levels of estrogen and progesterone. Sometimes people call it the change of life. Classically, people experience hot flashes, night sweats, sometimes some difficulty with sleep. People will sometimes notice some changes in their mood. Their mood is a little bit more up and down than normal. And another major thing that folks will often report is vaginal dryness. Menopause, either as a result of treatment or natural menopause, can persist for many years, and after either surgery, chemotherapy, radiation, or natural menopause. And it's something that I am not sure that we do a great job as oncologists talking to folks about as well. The main complaint when patients do tell me about this that is bothersome to them is hot flashes. The mainstay of therapy for hot flashes is something called hormone replacement therapy. We're going to talk about this a little bit more in a second. There are also non-hormonal therapies that can be used for hot flashes, which can also help night sweats. The difficulty with sleep is often associated with hot flashes and night sweats as well. And that includes, again, that class of medications called SSRIs, which is more commonly used for anxiety, depression, but has also been shown to help with hot flashes. Paroxetine, also called Paxil, is FDA approved for management of hot flashes. Gabapentin can also be used for hot flashes as well. Additional things that can be helpful for menopausal symptoms is cognitive behavioral therapy, yoga, and acupuncture. Sexual dysfunction often goes along with the people experiencing early menopause, and as well as the treatments that, again, we need in order to cure and treat these types of cancers. Sexual dysfunction is something that, again, we're not great at talking about as oncologists. It's often underreported because people worry that it shouldn't be a priority when they've gone through a cancer diagnosis. They worry that maybe their oncologist will judge them. They worry that it's something that, is not fixable or that there aren't interventions available for. And that's not the case. And so there's a fantastic lecture next week that's going to dedicate a lot more time to this, but I did want to go through things a little bit today. Sexual dysfunction is often related to a combination of a lot of different things that are going on for folks who are cancer survivors. It can be related to changes in anatomy, so vaginal shortening, if you've had a radical hysterectomy, a scarring or narrowing of the vagina, if you've had radiation treatment to the pelvis. For folks who've had vulvar cancer that affects the clitoris, sometimes the clitoris has to be removed, and that can impact people's sexual function as well. People can have pelvic floor tightness, both from treatment, but also from the trauma of having gone through treatment. chronic pelvic pain, vaginal dryness, loss of interest, which can be related to hormones, and it can be related to a lot of other things that change for folks when they're going through a cancer diagnosis. Anxiety, worries about sex after cancer, changes to body image as a result of cancer and cancer treatment, and changes that happen in your relationships, especially with intimate partners when you've gone through a cancer diagnosis. There are different things that can help. Hormone replacement therapy, which again, we're going to talk about in a little bit more detail shortly. Vaginal estrogen. Vaginal estrogen is different than hormone replacement therapy in that it doesn't travel through the whole body. It's vaginal cream or pills that just treat the vagina itself, and it can help to restore the more natural qualities of the vagina. So when somebody goes through menopause naturally, or because of cancer treatment, the vagina loses a lot of its elasticity or its stretch, and it becomes thinner and more fragile. And it also tends to develop dryness. And so vaginal estrogen can help to restore that normal healthy tissue of the vagina. Vaginal dilators, along with lubricants and vaginal moisturizers, can also be helpful. Some of you who've been through a GYN cancer diagnosis might have been recommended to use vaginal dilators by your radiation oncologist if radiation was part of your treatment. Pelvic floor physical therapy can be really helpful for sexual dysfunction, and then also seeing a specialist in sexual health. So either a gynecologic specialist who specializes in sexual health, or a psychologist, or there are also counselors who specifically specialize in sexual health. These are briefly some different resources that I did want to put out there for everybody. In the greater Rochester region, in terms of sexual health clinics, where I usually refer folks to is the Rochester Center for Sexual Wellness. They have a fantastic physician there, as well as a full complement of PAs and NPs, sexual health counselors, psychiatrists, and pelvic floor physical therapists. For folks who might be outside of the Rochester area or are only looking for, a specific component of support, there's the APTA, which is the Academy of the American Physical Therapy Association Pelvic Health Division. If you look on their website, you can search for registered pelvic health physical therapists in your area. There's also ASECT, which is the American Association of Sexuality Educators, Counselors, and Therapists. And if sex therapy is something, talking to a therapist specifically about your sexual health is something that you think might be helpful, and you don't need the other services that might come with a sexual health clinic, then you can also go online to ASEC's website and look up where certified registered sexual health therapists are in your community. There are also a lot of really great books written on the topic of sex and cancer. One of the books that I really like is in fact called Sex and Cancer, Intimacy, Romance, and a Love Affair Diagnosis After Treatment. This book was written by a GYN oncologist out in Colorado and one of his patients. They wrote the book together. So it's a pretty beautiful book, and it chronicles different stories from different folks who've been through a cancer diagnosis, and the forward is by Camille Grammer. There's also several websites and apps that I want to mention can be helpful. Middlesex MD is a great online resource for medically accurate and up-to-date information on menopause and sexual health. Woman Lab, vaginismus.com, Rosie, and Pelvic Gym are all combination apps and online websites that offer different sexual health programs. Pelvic Gym has pelvic floor physical therapy exercises that you can do independent of seeing a pelvic floor physical therapist, as well as different resources for sexual health. There are also some devices that can be helpful for sexual dysfunction for folks. One of them is something called an O-nut, and it helps to relieve discomfort that some people experience with penetration with intercourse, and that can be a really helpful device if that's where the dysfunction is and if that's where the pain is. And there's also something called cool water cones, which is a type of vaginal dilator that is different than the standard plastic or silicone dilators provided by radiation oncologists or GYN oncologists, and it can be a type of dilator that might be more comfortable for folks to use. And so I'm very excited for lecture next week and prepared to learn a lot along with all of you, but wanted to put some of these resources out there as well. Now, hormone replacement therapy. So hormone replacement therapy is a little bit of a contentious topic for folks who are GYN cancer survivors. Unique to folks who are GYN cancer survivors and also breast cancer survivors is that GYN cancers and breast cancers are often hormonally mediated. And so while we would like to be able to give everybody who's gone through a GYN cancer diagnosis and has gone through menopause because of that cancer and that treatment, hormone replacement therapy, it might not be safe for all people. And there are some specific cancer diagnoses where it can actually increase the risk of recurrence, and it really needs to be avoided. Hormone replacement therapy includes hormone pills or patches to replace the hormones that we would normally have circulating through our whole body, as well as a vaginal estrogen cream, which we talked about a little bit previously to help with vaginal dryness and vaginal health. There are two hormones that the ovaries make, estrogen and progesterone. And it's really, really important that if you are somebody who still has a uterus, you cannot take estrogen alone. Estrogen alone increases the risk of endometrial cancer substantially. You need progesterone to balance it out. So if you're somebody who's talking to your provider about hormone replacement therapy and you still have a uterus, even if you've gone through menopause, you have to go on the progesterone to protect your uterus. Now, if you're somebody who no longer has ovaries or a uterus, or the ovaries have, been damaged by treatment and the uterus is no longer there, then in that case, you can go on estrogen therapy alone. You don't need the progesterone component to protect the uterus. Hormone replacement therapy is generally considered safe for certain types, folks who are survivors of certain types of ovarian cancer, folks who are cervical cancer survivors, those specifically cervical adenocarcinoma. The research is a little on the fence. And so that's something that you really need to talk to your provider very carefully about. And generally considered safe for folks who are vulvar and vaginal cancer survivors. It is not safe for folks who have had endometrioid type or low-grade serous ovarian cancer, granulosa cell ovarian cancer. All three of those types of ovarian cancer are driven by hormones. So taking hormone replacement therapy in that situation can increase the risk of the cancer coming back. Also, for folks who have had what's called uterine leiomyosarcoma or an endometrial stromal sarcoma, those are also hormonally mediated. And folks who've had advanced endometrial cancer, it's not safe. And in folks who are breast cancer survivors, it's not safe. It's unclear right now if it's safe for patients who are early stage endometrial cancer survivors. And it's a conversation that really should be personalized to your situation and should be had between somebody who understands and knows your cancer diagnosis well, and what you've been through and what your risk of recurrence is. Another thing I want to talk about briefly is loss of fertility. So unfortunately, with GYN cancers, and there are associated treatments in folks who are premenopausal, reproductive age, loss of fertility is often a side effect. Unlike when we treat cancers in other parts of the body, because this type of cancer affects the reproductive organs, the ovaries, the uterus, the cervix, treatment for that often results in difficulty getting pregnant or an inability to get pregnant. Oftentimes, treatments for these type of cancers include removal of the uterus, ovaries, and tubes. Chemotherapy and radiation can cause the ovaries to go into menopause early, temporarily or permanently. And really importantly, folks who receive radiation for cervical cancer or endometrial cancer, the radiation causes significant scarring within the uterus and the cervix. So even for those folks who, are cervical cancer survivors who still have ovaries and a uterus, the ovaries might wake back up over time, but that uterus is never going to be able to safely carry a pregnancy because of that scarring. Hopefully these are things that are discussed with folks before going through cancer diagnosis. But I have to recognize that as a field, oncologists don't always do a great job talking about how treatment might impact fertility. If you're somebody who with a new cancer diagnosis, who's reproductive age and hoping to potentially still be able to grow your family and carry a biological child, please ask your oncologist if fertility sparing options are something that might be available to you. They're not available for all cancer types, and they're not available for all cancer stages either. Other things to think about either after going through cancer treatment or before is seeing a reproductive endocrinology and infertility specialist. They can help with things like egg retrieval, IVF, surrogacy, and then, adoption is also a way in which people will sometimes choose to grow their families. Next up, I want to talk about osteoporosis. So osteoporosis is decreased bone density and increased risk of breaking a bone. especially the hips or thigh bones, also known as the femurs, the upper arm, the spine, the vertebrae, particularly compression fractures. The reason why GYN cancer survivors are increased risk of osteoporosis is because of early menopause. So folks who go through menopause early and don't have that hormone benefit on their bones long term, the bone health is determined by our hormones. And so when we lose our hormones early, we're at increased risk of having poor bone health. The other thing that increases the risk of osteoporosis is radiation therapy itself. It does decrease bone health, bone density. There are actually really firm recommendations within the field of GYN oncology for osteoporosis screening and management. So all folks who've gone through a GYN cancer diagnosis should have what's called a DEXA scan, which is a bone density scan after completion of treatment. Normally, this type of scan isn't offered to folks until they're age 65, but if you're younger than 65 and you're a GYN cancer survivor, you are increased risk of osteoporosis, and you should talk to your oncologist or your primary care provider about getting that baseline DEXA scan early, and then regular long-term management with DEXA scans as well. In terms of prevention of osteoporosis, things that are good for our bone health is eating a diet that's high in calcium and vitamin D. Some people will talk about taking calcium and vitamin D supplements. Our bodies are not as good at absorbing calcium and vitamin D from supplements as they are from absorbing those things from our actual food. And then vitamin D, of course, is related to sun exposure as well. Weight-bearing exercise is really good for bone health and important for bone health. By doing any sort of exercise, walking, running, lifting weights, anything like that, riding your bike, putting weight on your bones helps to encourage your bones to remodel and to create new bone. Unfortunately, something like swimming, while it's fantastic for your heart health and your lung health, it doesn't help your bone health at all because you're not putting any weight on your bones when you're swimming. Smoking is also one of the major contributing factors to poor bone health, and so quitting smoking helps decrease the risk of osteoporosis. In terms of treatment for osteoporosis, there are different medications that can be prescribed to help try to improve your bone health over time, in addition to those prevention lifestyle changes that I discussed. A lot of folks who are GYN cancer survivors do deal with bladder issues, such as urinary leakage and pelvic floor prolapse. This can be related to surgery from hysterectomy, and it can also be related to having had radiation therapy, if that was something that was part of your treatment course. The first recommendation I have is to talk to your primary gynecologist. Gynecologists are really skilled at helping folks with urinary problems and pelvic floor issues. If you've already talked to your regular gynecologist and are still struggling, then it might be beneficial to see what we colloquially call a urogynecologist, but they're formally called a female pelvic medicine and reconstructive specialist. Urogynecologists are OBGYNs who've done additional specialty training in pelvic floor medicine. The other things that can be helpful is something called bladder training. And so it's a way of helping to train your bladder to hold larger volumes of urine. Along with that, kind of slowly over time, along with that, there are some different foods that can be more irritating to the bladder. So avoiding foods that are spicy, high in citrus, can help to calm the bladder down when it's really irritated. Maintaining a healthy weight helps decrease urinary leakage and pelvic floor prolapse. Pelvic floor physical therapy, again, can be really helpful. A pessary can be helpful for some folks, and there are also medications for overactive bladder. Some folks can have, not just urinary leakage, but chronic bladder irritation. That's usually due to radiation therapy. A lot of folks, most folks who go through pelvic radiation will have irritation during treatment and for a couple of weeks afterwards. And usually that gets better with time. For some folks, it never truly gets better. And in that case, that's usually related to, scarring and thickening of the bladder related to the radiation long term. In that case, those folks might benefit from seeing a urologist, so a bladder specialist. And sometimes there are some different treatments they can do to try to help expand the bladder and stretch it out to a more normal capacity. And then there is the option of what's called hyperbaric oxygen therapy, which is a way of trying to promote healing using hyperbaric oxygen therapy chambers. It's a pretty unusual treatment. Hyperbaric oxygen therapy chambers are not easy to come by, but if people are having really severe symptoms that don't respond to other types of treatment, it is something that can be looked into. Along with the bladder, a lot of folks who are GYN cancer survivors do struggle with bowel issues. And so they can run the gambit from diarrhea to constipation. Diarrhea is usually due to radiation, though. And so folks who are on pelvic radiation often will struggle with diarrhea during radiation and right after. Usually that gets better, but for some folks, they can have lifelong issues. For those folks, antidiarrheal medications like loperamide, also known as Imodium, can be helpful. And then stool bulking agents like taking psyllium husk, which is called Metamucil in the store, and fiber can be helpful for regulating the bowels. Constipation is something that a lot of folks who've been through chemotherapy will struggle with long term. It's something that a lot of folks struggle with who even aren't cancer survivors. And constipation is best managed by, changes to the diet, um, prioritizing like high fiber foods, making sure that you're keeping yourself really well hydrated. Being active is one of the most important things for bowel health. Walking is so important for keeping the bowels regular. And then using laxatives and stool softeners as needed. And if you're really struggling with chronic constipation, that's not getting ready better with those, more easily implementable things I talked about, then seeing a gastroenterologist or a GI specialist can be helpful. Fatigue and memory problems are something that a lot of folks who are cancer survivors struggle with. And it's one of the most difficult things I think to help folks with. Um, It affects cancer survivors in many different ways, and it's not just tiredness. And I hear this from my patients all the time, both who are actively on treatment and who are in remission, is that fatigue doesn't even describe how they feel. Like it's not just tiredness, it's not just feeling unwell, it's not just feeling exhausted, it's a completely different experience. I think one of the hard things is that, especially when somebody is done with treatment, a lot of times folks in your life expect you to go back to normal. Life after cancer is never going to be the same normal as it was before. It's going to be a new normal. But I think the folks around cancer survivors often don't anticipate or understand that that fatigue doesn't necessarily go away and how it might continue to impact somebody. About 25% of folks experience fatigue long term. There's also something called post-chemotherapy cognitive impairment, which is a growing area of ongoing research. A lot of people will talk about chemo brain when they're on chemotherapy. And there's increasing evidence and research showing that, there might be some changes related to going through cancer treatment and also efforts of how do we support people with that. If you're dealing with fatigue and memory problems long term after going through a GYN cancer diagnosis, it is really important to make sure that there's not something else going on as well. So anxiety, depression can show up as fatigue and memory problems, low blood counts, so anemia or other bone marrow issues, low thyroid function, diabetes, and also things like dementia or Alzheimer's can present with fatigue and memory problems. So we want to make sure that if that's something that's going on in your life long term, that we're ruling out those other things and not just attributing it to having gone through cancer treatment, because we never want to miss something that we might be able to intervene on. Strategies to try to help with fatigue and memory problems. It's really hard, but maintaining a physically active lifestyle. Um, it sounds crazy, but keeping that activity level up does help to combat the fatigue and prevent the fatigue from getting worse. But that's a lot easier said than done when you're struggling with the fatigue from cancer treatments. Do things that exercise your brain. So physical activity is great, but brain exercises are so important. So if you're somebody who likes crosswords or Sudoku, or you like creative writing, or you like reading books, all those sorts of things, anything that exercises your brain is really important. Good quality sleep, good nutrition, keeping a regular daily routine is really helpful for fatigue. Use of memory aids, cognitive behavioral therapy, and support groups have been shown to help with long-term cancer treatment-related fatigue as well. In terms of mental health is a huge thing that, again, I think we don't do enough justice to when supporting folks who've gone through a cancer diagnosis. And again, I think, people anticipate anxiety, depression, and difficulties with mental health when they're on cancer treatment. And then after cancer treatment, there can be a lot of expectations of going back to normal, and that normal is going to be different. And so dealing with those expectations of those around you and also potentially living in a body that feels very different. About 40%, 6% of cancer survivors report living with anxiety, and about 20% report living with depression. And many cancer survivors describe living with a constant fear of recurrence, which I talk with a lot of my patients about, and figuring out strategies with your oncologist to help deal with that fear of recurrence can be really helpful in managing your mental health after cancer diagnosis. Other stressors, like I was mentioning, that can contribute to somebody's mental health when they've been through a GYN cancer diagnosis and treatment is identity loss. A lot of folks do struggle with not feeling like the same person they were, not recognizing themselves either from physical changes or emotional changes. The stress of returning to work if you're somebody who works outside of the home, the stress of returning to caregiver responsibilities if you're somebody who's always been the caregiver for others. Family dynamics can change, intimate relationships and partnerships can change, unfortunately, because of a cancer diagnosis, and that's not uncommon. Insurance issues, and then additionally, the financial toxicity of cancer treatment and follow-up can negatively impact people's mental health tremendously. In terms of what we can do to help support folks who are GYN cancer survivors, individual counseling is tremendously helpful if it's something you're open to. Cognitive behavioral therapy as a component of counseling is a specific strategy. Mindfulness exercises, creative outlets like art therapy, creative writing, support groups, finding your survivor community. So finding people who can relate to what you've been through and can provide that support that somebody who hasn't been through a cancer diagnosis just can't. And then, of course, there are medications that are important mainstay and helping support people with anxiety, depression as well. And just a reminder, I think especially when somebody's gone through a cancer diagnosis and after treatment and those appointments are no longer as regular and you're not going in for treatment all the time and seeing your team, you still matter to your oncology team and you still matter to this world. Briefly, I wanted to touch on some additional resources for GYN cancer survivors. So the National Organization of GYN Oncologists is called the Society of Gynecologic Oncology. That's where our different treatment recommendations come through, our research on treatments for GYN cancers and everything associated with that. So with quality of life and long-term side effects, it all comes through SGO. There is a research arm called GOG, and then there's also the patient arm of SGO, which is called the Foundation for Women's Cancer. The Foundation for Women's Cancer has their own website and is their own side-by-side organization with SGO, and it's an incredible website with a lot of resources on it. If you haven't checked it out, I would highly recommend it. They have a survivorship toolkit, which has different survivorship care plans. These are documents that your oncologist might offer to fill out with you anyways. Some people do it standardly. Not all clinics are set up to do it. But they have these great documents where, you can sit down with somebody from your oncology team and fill out and understand exactly what you went through for treatment, what you received. And then they've also got great guidelines in terms of what healthcare maintenance should you need, what things should you be mindful of, as well as talking about different wellness and preventative health issues. They also have calendars to help keep track of things when you're in remission and in survivorship. That is all I have for you folks today. I wanted to say thank you so much to all of you who've joined, and also thank you to the Breast Cancer Coalition for inviting me to speak today, and very excited to be able to speak during the month of September, which is Gynecologic Cancer Awareness Month. And so honored to be here and looking forward to being able to interact with you all and answer questions along with the other panelists in a couple weeks.
Wow, that was really, really informational, jam-packed. I'm really excited that this is being recorded. So of course, if you want to review it, it'll be up on our website later today. Thank you so much, Dr. Rubin, for sharing your expertise. You've got to be really thirsty now. That's all I can say.
Just a little thirsty, but it was worth it.
Wow, just amazing. All right, I'm getting some great questions in the chat. Keep them coming because we will save these all for Wednesday, September 25th, 7 p.m. We've got a question and answer panel. Dr. Rubin will also join Dr. Angel as well as Christina Galton to answer all these questions. So feel free to review those recordings and come up with as many as you've got. It's wonderful.
You can also email them to us. You can email them to the info@bccr.org. address, or you can email them directly to Christina or me, and we will compile everything and have it ready. But we'd also love to see you in person. So doing both would be great. And then just to reiterate too, the seminar next week on sexual health specifically, I'm really excited. Thank you so much for touching on that, Dr. Rubin. And I learned so much. It was riveting. But I think the more we can do to encourage folks to invest in themselves, regardless of whether there are social stigmas or not about, yeah, being a sexual person, but also just feeling embodied, no matter how your body has changed as a result of the course of treatment and afterwards. It's about feeling connected to yourself, no matter what form that is in. So please tune in next week. I know that our registration numbers were markedly lower next week than they have been for all the other webinars. And that makes me, it's a concern. So I would love to see you all there next week as best I can. And if we can chip away at these social stigmas and barriers to care, it's worth doing.
Absolutely. Thanks again, everyone. Enjoy the rest of your day.